Dr. Neil Trivedi, Senior Consultant Urologist at KIMS Hospitals. Today's topic is men's health awareness, and it is very important to know the points regarding the men's health awareness. Next slide, please. So it is Men's Health Awareness Month, and 19th November has been the International Men's Day. So I will be talking a few topics regarding the men's health awareness, and I will be stressing on the prostate and the testicular health. Next, please. So these are the topics, and I will be, as a urologist, I will be stressing on the prostate health, the importance of early detection of prostate cancer, the testicular cancer, importance of early detection, and also I will mention regarding why is life expectancy of men less than women and how can men stay healthy. So the most important topics of today's discussion will be the prostate and the testicular health. And in prostate, I will be covering regarding the BPH, that is the benign prostatic hyperplasia, and the prostate cancer. Next slide, please. So as I mentioned, in the prostate health, we commonly hear the term that is BPH or benign prostate hyperplasia, and the next is prostate cancer. And in testes, the important topic is testicular cancer. Next slide, please. So first, let me introduce you to the prostate gland. That is, what is prostate gland? What are the diseases that happen in the prostate gland? How we diagnose them and how we treat them. Next slide, please. So here we see the cutout of the prostate gland. As you can see, the cutout of the bladder is seen, and below there are the lobes of the prostate gland, right and left, and in the center there is the urethra. So this is the normal anatomy of the prostate. It is a secondary sex organ in the males, approximately of the size of a lemon. It is situated below the urine bladder. It encircles the initial portion of the urethra, referred to as the prostate urethra, and it usually enlarges after the age of 50 years. Next, please. So here we see that what are the diseases that affect the prostate. That is the inflammation of prostate, or called as prostatitis, the benign prostate hyperplasia or the normal enlargement of the prostate, and the prostate cancer, that is CA prostate, referred to as CA prostate. Next, please. Now here we see, if we compare to the previous diagram, on the left side we can see mild BPH, that is a mild enlargement of the prostate, where you can see that the urine passage is getting a little bit narrow, and when the gland gets more enlarged or referred to as severe BPH, there is a more constriction of the urine passage, and sometimes it can lead to urinary retention also. Next, please. Now, what are the symptoms which are caused by the enlarged prostate gland? These are classified into two different types of symptoms, referred to as the obstructive symptoms or voiding symptoms, and storage symptoms or the irritative symptoms. Next, please. So this is the IPSS scorecard, or the International Prostate Symptom Score. These are all the symptoms which are caused by the enlarged prostate, namely the frequency or urgency, nocturia, the weak stream, straining, and resulting in residual urine volume. I will come to that in the next slides. Next, please. So as I was mentioning, that there are different symptoms are caused because of the enlarged prostate. Some are due to the obstruction of the prostate, and some are due to the storing of the urine inside the bladder. The obstruction causes a poor stream of urination, and resultantly the patient starts straining to pass urine. So straining, and there is a feeling of incomplete voiding from bladder. Some there is a post-voidal residual urine, and sometimes there is a dribbling after passing urine. Next, please. And the storage symptoms are frequency, because the urine doesn't get completely emptied. Therefore, the patient goes for urination more frequently. Urgency, which means that after the bladder sensation is sensed by the brain, the patient is unable to wait till he goes to the bathroom, or he has to go for urination very urgently. Sometimes also there is a urgent urge incontinence. That means the patient may wet the clothes before even reaching the bathroom. Nocturia is nothing but frequency in the night. This is sometimes the initial symptom of BPH. In this, the patient may have to get up 2 to 3 times in the night or sometimes even more to pass urine. This is referred to as nocturia. Next, please. Now, once we have these type of symptoms and we have done the scoring as I showed in the previous slide by the IPSS score, then we further go for the investigation and then how to go for the further treatment according to the results of the investigation. So now I will be telling the importance of each investigation and how it helps us in the further treatment of the enlarged prostate, which is referred to commonly as the BPH. Urine analysis is a very simple test. It gives us information whether the urine is infected in the form of pus cells or referred to as WBC, whether there is any blood in the urine, whether there are any crystals in the urine, whether the urine is clear or it is hazy. The hazy urine suggests that there might be infection in the urine. Urine culture and sensitivity is helpful when there is a patient who is having fever and therefore resulting from the urine infection, and culture and sensitivity will tell us that which appropriate antibiotic can be used for that particular patient. Next is the complete blood count, the urea creatinine. Urea creatinine is important to know whether the sometimes the prostate enlargement can cause back pressure changes and therefore it can cause the changes in the renal function. And renal function can be assessed by this test called as the urea creatinine. Ultrasound KUB with the post-word residue, that is the PVR. The uroflowmetry and serum base. I will come to these topics later. Next, please. It is very important to note that the urine sample should be collected properly, otherwise the results may not come correct. By proper correction, I mean that the patient should clean the private part, retract the prepuce, and then he should collect the midstream sample of urine. That is, the initial portion of urine should be discarded, and then the midstream sample should be collected so that a correct result can be gained. Next, please. Now coming to the ultrasound. The ultrasound is a very important investigation. It is also a non-invasive investigation which can be easily performed, and it gives a lot of information regarding the prostate and the other parts of the urinary tract. Prostate, it shows the size of the prostate in the prostate. Regarding the bladder, it shows the bladder wall thickness. Suppose the bladder wall thickness is increased, it means that the symptoms have been there for a longer time. Wall thickness can also increase in cases of cystitis. The other important information which are available from the ultrasound are the post-void residual urine. Post-void residual urine is a very important information which will give us the baseline evaluation of how much the residual urine is, whether it is significant or not. And also it can be measured as a follow-up investigation where we can assess how much the patient has responded to the medical management, and therefore we can plan the treatment accordingly. And then the other information which are available from ultrasound are presence or absence of calculi, presence of trabeculations or diverticulum. Diverticulum is a outpouching in the bladder, and these trabeculations or diverticulum happen because of long-standing obstruction to the outflow of urine, namely by the prostate or sometimes because of stricture. Here we are talking regarding the BPH. Therefore, it would be that because of the outlet obstruction due to the enlarged prostate, we can see some of these complications inside the bladder. And when there are complications due to the enlarged prostate, it becomes a definitive indication for going for operative management, that is going for surgery. And information regarding the upper tract, namely the kidneys and ureters. So when there is a long-standing obstruction from prostate, sometimes we see a dilatation of the ureter referred to as hydroureterosis, and sometimes dilatation of the kidney referred to as hydronephrosis. So if these are present, it means that back pressure changes have occurred because of the enlarged prostate. Next, please. Now the flow studies, that is how the urine is flowing, whether it is obstructed or not obstructed, can be assessed by a very easy test called as the uroflowmetry. The uroflowmetry graph, as you can see, the first one on the left is a normal urine flow, which shows that there is no obstruction. On the right, you can see the obstructed flow of urine and so on. Urodynamic study, the uroinflammatory study is done for all the patients where for assessment of BPH. However, the urodynamic study is reserved for those patients whom we feel that there is suspicion that the bladder is not contracting properly, which means that the tone of the bladder has reduced. So in these circumstances, we do a urodynamic study, and it is very important to do this urodynamic study for a proper assessment whether the operative management would be beneficial or it would not be beneficial in the particular case. So when there might be two components of the patient not being able to pass urine. One is the obstruction, the physical obstruction of the prostate gland, which is constricting the urine passage. And second is if the bladder is not contracting properly, then also the voiding may not be normal. And in these circumstances, also patient might be in urinary retention. So when we see a patient who is having a very large post-void residual urine, or if patient comes in retention and after passing the catheter, we get a very large volume drained. For example, 1 liter of urine or sometimes even more, then we suspect that the bladder contractile has been affected. And in such circumstances, if a obstruction is cleared, that is by doing a TRP or a HOLEF, still the patient is unlikely to pass urine normally. And therefore, in such circumstances, we can avoid the operative management or then offer a different type of management in the form of a self-catheterization or catheterization wherever indicated. Next, please. If there is a very high post-void residual urine, if there is a stone formation in the bladder, and if there are back pressure changes, then in such cases, it is indication for going for a surgical management, which would be in the form of either TURP or holmium laser enucleation of prostate. The TURP as of now is a very gold standard procedure and can be easily reproduced by many of the surgeons, whereas the holmium laser enucleation of prostate is slowly gaining popularity and is now coming up, and eventually it may replace the TURP. In this, the laser energy is used to do a enucleation of the prostate gland. In the TRP, there is no enucleation. The small pieces of the prostate gland are made and the prostate obstruction is cleared. Next. Now, what are the important take-home messages for BPHs? One should not neglect the symptoms of BPH, which I mentioned earlier, and treatment opinion should be taken and appropriate treatment should be started. If in earlier stages of the BPH, it is amenable to medical management, which means when there is an enlarged prostate without any presence of complications and mild symptoms, then such cases respond well to medical management with the drugs known as the alpha blockers like tamsulosin and silodosin, etc. In patients who are having complications like the ones mentioned below, that is repeat urinary tract infection, presence of stones in bladder, high post-void residue, and raised serum creatinine, these are the patients who will require the surgical management for clearing the obstruction of the prostate. Next. So important is the patient themselves should not neglect the symptoms, and other family members also should keep their symptoms in mind, which I mentioned earlier and showed in this picture. If any such symptoms are present, which means that the urinary stream is weak, or the patient has to strain for urination, or is going for urination very frequently, or is getting up at the night very frequently, or if there is a post-void residual urine, then definitely the advice of urologist should be taken and appropriate treatment should be done. If the surgery is indicated and it is postponed because of the anxiety, because of the fright of going for a surgery, then eventually the patient may land up in retention or other complications. And when finally the treatment is taken, it may not have as good results as it should have if it would have done earlier at the first indication for surgery. Next, please. Now coming to the second topic regarding the prostate cancer. Next, please. If you compare to the previous image of the prostate, you can see here that the anatomy of the prostate is completely destroyed, and the prostate cancer, this diagram depicts the prostate cancer, and you can see on the left side that the gland is enlarged and it is going infiltrating or penetrating into the bladder. Next, please. Okay, what are the risk factors for the prostate cancer? The risk factors are increase in age. So as the age increases, the chances of prostate cancer also increase. The geographic variation, it has been found that more common in Western countries and less common in the Eastern countries. Family history is very important risk factor for prostate cancer, as we see in the next slide. And to certain extent, an exercise that is a 1 hour of strenuous exercise is found to have a decreased risk. That means a little bit of protective effect regarding prostate cancer. But these are studies, and this has not been proved. But some of the studies have shown that regular exercise can have a protective effect on prostate cancer. Next, please. So, as I was mentioning regarding the family history, if a person's father is affected at any age or brother is affected, then he has got a 2.35 times increased risk of prostate cancer. If brother is affected at any age, the risk increases, that is 3.14 times more risk. And if first degree relative is affected at any age, there is a 2.48 times increased risk of prostate cancer. And if affected first degree relative is diagnosed in less than 65, then the risk is 2.87 times more. And if the first degree relative is diagnosed. So, what is the importance of awareness? Why we are talking about awareness? Most of our cases which we now see in today's practice, 75% to patients come in an advanced stage, and therefore there is an importance of the screening by the methods of DRE, digital rectal examination, and serum PSA. Next, please. So this is what is the digital rectal examination. Because of the close proximity of the prostate gland to the rectum, that is the motion passage, the urologist can easily feel the prostate gland and gain some details about it from the rectal passage. Next, please. So what information can be obtained from the digital rectal examination or the rectal examination is to feel the prostate gland, observe its size, and that is whether the finger can be put beyond the upper border of the prostate or not. If the prostate is large in size, then the radiologist may not be able to put the finger above the upper border. So this gives a rough idea about the size. What is the consistency of the prostate, whether it is firm or hard? In normal circumstances, the prostate would feel firm. If there is a doubt of cancer, then it would feel hard. Whether presence of nodule or not. If there is a nodular feeling, then it is more likely to be dealing with a malignant enlargement. If there is tenderness, it points more towards prostatitis, that is infection of the prostate. If the mucosa, whether it is free or not, if the mucosa is fixed, then it gives a doubt of prostate cancer, and whether the anal tone is normal or not. The anal tone is a point which is important for the fact which I was mentioning regarding the urodynamic study and whether we are suspecting that the bladder contractility is normal or not. So when the anal tone is normal, usually the contractility to bladder would be normal. And if the anal tone is lax, as we call it, then we suspect that the contractility of bladder may be affected. And this is one of the indications where we should do the urodynamic test. Next, please. Coming to serum PSA, it is a simple blood test. It is a tumor marker which makes us to suspect that we may be dealing with a case of prostate cancer. And no need of fasting. This I mentioned, no need of fasting, because many of the times the senior citizens, they tend to avoid being further tested. They feel that it is because of age and they don't want to get further tested. So it is no need of fasting required, and blood sample can be given immediately for testing. Next, please. So what would be the results of PSA? These are the possible results of the serum PSA. 0 to 4 is referred to as a normal PSA value, and in such cases also it has been found that 25% of the cases may have biopsy proven CA prostate, and in these cases almost all will be localized. By localized I mean that organ confined, that the cancer has not spread beyond the prostate gland, and in such circumstances it is possible to give a curative treatment. 4 to 10 PSA, also referred to as the borderline PSA, and in these cases, 70% of the biopsies would turn out to be positive, and 60% of these would be dealing with the localized prostate cancer. In 10 to 20, if the PSA is 10 to 20 nanograms per ml, there is a high risk of micrometastasis, and usually the metastasis from the prostate commonly happens to the bones. Next, please. When we are having a PSA value of 20 to 50 nanograms per ml, there is a chance that in 70% of such patients, there will be metastasis to the bones. If the PSA is more than 50, it is observed that 75% such patients have bone and lymph node metastasis, that is, spread to the bone and the lymph nodes also. Next, please. So there is a concern regarding a raised PSA. Whenever the patient sees a PSA is raised, they all become very tensed and they are worried about the PSA report. But we should also rule out other factors which can cause the rise in PSA. And these are the other factors which can cause rise in PSA, which are urinary tract infection, a large volume of prostate gland. After a digital rectal examination, also there might be raised PSA. Within 48 hours of ejaculation, patient who has had acute retention of urine, those who have inflammation of prostate gland, which is referred to as prostatitis. After catheterization, if patient comes with retention and has been catheterized, in such patients also the PSA could be raised. And after any periurethral endoscopic procedure like cystoscopy, so if any endoscopic procedure has been done through the urethra, in such patients also the PSA will be raised. So when we see patients where we suspect other reasons for rise of PSA, usually we give a small course of antibiotic. If we are seeing a reducing trend of PSA, it means that we are not dealing with a prostate cancer. But if the PSA is either remaining the same or if it shows any increase, then definitely we have to go for a prostate biopsy. Next, please. So what do we do when we have either a raised PSA or abnormal findings on digital rectal examination? If both are normal, we should put the patient on screening. But if one or both are abnormal, then patient is advised to undergo the prostate biopsy, which is nowadays for the transrectal ultrasound guided biopsy. If it comes normal, then again the patient is put on annual screening, that is yearly screening. And if it is abnormal, then one has to work up and plan for the radical treatment. Next, please. So, how a patient is prepared for the TRUS biopsy? The TRUS biopsy always should be done under antibiotic, which is sometimes it is likely to cause post-biopsy infection, and sometimes it may be so severe that it can lead to sepsis and sometimes recovery, admission also to the ICU. Then they have to check the PT and INR. These are the factors of coagulation, whether the blood is going to coagulate in the normal time. So this is very important to note before a biopsy is done. If the patient is taking any antiplatelet drug, then they should be discontinued. The patient should be given a laxative before the biopsy previous night so that the bowel is cleared and it doesn't come with, there is no feces in the rectum so that the biopsy can be done properly. And there is a, we explained to the patient regarding the small possibility of sepsis, which I was talking earlier. That is a severe infection which can happen sometimes. The incidence is very low. And post biopsy, there can be blood in urine, referred to as hematuria, and there can be bleeding per rectum also. These are the possibilities after a TRUS biopsy is done. Next, please. So this is how a TRUS biopsy is done. Down below, you can see the probe, and on that there is a instrument which can be fixed through which the needle is guided. So you can see that the needle is going and taking biopsy from the prostate. Nowadays we follow the 12 core biopsy so that we should not miss any portion of the prostate gland. We see the findings on the TRUS ultrasound and accordingly we guide the needle to the particular area from where the biopsy has to be taken. So 6 cores are taken from each lobe of the prostate. There are 2 right and left lobes, and from each area of the prostate, we take the 6 core biopsy, 6 from each lobe, so as not to miss any portion of the prostate. Next, please. So once the biopsy result is available, there will be two possibilities. One is the organ confined, that is the cancer is limited only to the prostate gland, and the other is whether it has spread to other parts in the body. So if it is organ confined, there are some options, and surgery is the best option. The which are available are radical resection and radical radiation, and this is given in the form of external beam radiotherapy, intensity modulated radiotherapy, conformal radiation, or brachytherapy. Brachytherapy is where the radioactive needles are put inside the prostate, and they remain there and deliver the radiotherapy to the prostate gland. Another option would be primary androgen blockade, and this is reserved to those patients who are not fit for radical surgery or radical radiotherapy. Next, please. So this is regarding the chemotherapy or the management of patients who are having metastatic prostate cancer. I will not go into the details of this treatment. Next, please. Now, what are the important messages that we should take down? Prostate cancer is probably more common than we actually think in our country, and common cancer in men globally. More than 1.4 million men are diagnosed with CA prostate, and more patients are diagnosed because the longevity has increased, and we are seeing more and more cases of prostate cancer. Next, please. So it is important to diagnose the prostate cancer early because most of the patients, as I mentioned earlier, approximately 70 to 75% patients, what we see, they present to us in the advanced stage, and therefore there is no possibility of offering a curative treatment. And therefore, it is important to diagnose the prostate cancer early. A screening program which is not there in our country, so asymptomatic. The radical prostatectomy is the most effective method of treating the organ confined disease, and this is the best and only treatment for organ confined disease because it offers the curative treatment. Next, please. So, coming to the myths or the misconceptions regarding the CA prostate. First one being that CA prostate is uncommon in India. This is completely false. The fact is that it is the second leading site of cancer in elderly males in large cities like Delhi, Calcutta, Pune, and Trivandrum, and it is third in Mumbai and Bangalore. So sadly, more than 50% are diagnosed in the late stage. Next, please. The next myth is that occurs in elderly men. Yes, it does occur in elderly men, but it has been found that in 30% of patients below the 65 years of age, also the prostate cancer has been detected. That is why we are starting the screening at 50 years. And positive family history, as I mentioned in the previous slide, it doubles the risk of prostate cancer. Next. Other myth is that high PSA means CA prostate. No, it does not. It can be due to many other things like high prostate volume, urinary tract infection, prostatitis, and therefore let the urologist decide. Don't panic. Consult the urologist and let him decide by the digital rectal examination and the PSA and other investigations like transrectal ultrasound that whether we are dealing with prostate cancer or not. Next, please. The other myth is biopsy will lead to spread of prostate cancer. This is completely wrong, and biopsy is essential to confirm the diagnosis and plan the treatment of prostate cancer accordingly. Next, please. The other myth is that many men die with prostate cancer rather than of prostate cancer. This is also wrong. There is because of the metastasis that is seen, 50% of patients are dying, and the disease is severe and distressing, and there is a poor quality of life. Therefore, again, I keep on stressing that it is important to diagnose the prostate cancer early. Next, please. Now, the myth is that robotic or laparoscopic surgery is the best treatment. That is also not true. All the three methods of treatment, namely the open, laparoscopic, and robotic, have got equal results, giving complete clearance in experienced hands. Most important point in this is that applying strict and sound principles of cancer surgery is important. Next, please. So now coming to the last topic, which is the testicular cancer. Here also, again, it is important to do. Next, please. So globally, testicular cancer is the most common cancer among men. Thumb and index finger can feel for each testis separately. So if there is anything, a lump-like thing which you feel, then you should go and consult the urologist regarding the same. And testicular cancer can so be detected earlier, and definitely it can be treated before it spreads to other parts, so that also the curative treatment can be offered. Next, please. Now coming to the last part, which is more of a psychiatric topic rather than the urology. I just mentioned some few points. Then how can men stay healthy? They should spend time with the ones who make them feel happy. Talk more, move more means be involved in regular exercise, do yearly checkup, and do testicular self-palpation, which I just mentioned. Next, please. So I end the talk with a quote that health is not valued till sickness comes by Thomas Fuller. Thank you. And now we'll take some questions. Okay, okay. There is nothing in the